everybody. Welcome to Reimagining Healthcare, a new dialogue with risk and patient safety leaders presented by MedPlace. We're excited to bring you conversations with top risk and patient safety thought leaders from organizations around the country. Please subscribe to get the latest news and content. And if you found value from this episode, please share it with your colleagues to create meaningful dialogues in your community. Also, if you're interested in participating as a guest, please send us an email at speakers@medplace.com. And so today I'm really happy to introduce you guys to someone that's been an advisor to MedPlace really since our inception. Dr.Ara Feintstein joins us today. He's a top trauma surgeon in a large hospital system. He's got a ton of experience. I'll let him give you a little bit of his background here. But Ara's been, really advising MedPlace from a clinician's perspective from the get-go, really in terms of how we're, approaching the market and what we're thinking about things. And so I've really valued his insight. And Ara, thanks for joining me today.
Well, thanks for having me. Great chance to talk about some things that you and I are pretty passionate about, including things like peer review.
Indeed. So for everybody or anybody who doesn't know you, and you've got a strong online presence, I would say. Enjoy watching the types of ideas and things that you put out there. But can you tell us a little bit about yourself?
Sure. I always start by saying I'm a trauma surgeon by trade. Still like to be in the trenches, taking care of people. And I think no matter what I do, that's sort of how I identify. And I think that um, that's what probably informs most of my perspective on things. Still being that real boots on the ground, and seeing patients and talking to other doctors and talking to nurses and just really understanding healthcare at that level. But then I also I'm really lucky to support the whole range of adult specialists for a large integrated health system called Banner Health here in Arizona. And so I get to work, across the system. I get to understand how different specialties work and what different physicians need in their practice. And then I get to kind of also take a look at how that healthcare system evolves and work with my insurance division partners and really get my sleeves rolled up in how healthcare is working and sometimes not working. And that I also have a master's in public health, so that part of my education I think factors in a lot in that healthcare transformation piece. But I also realize that healthcare is going to need to be changed from the outside, and that there needs to be innovation and companies that are more venture based and agile and trying to solve problems that we might not see as well internally. And I think that's a great segue into this conversation and why I've really enjoyed the work with MedPlace, because I think that's exactly what you guys are doing.
Yeah, first of all, it's been helpful as we're been assembling this, large group of specialists around the country and their different backgrounds. It's been helpful to be able to leverage you for, how we do that appropriately. But it's also great to think about with you what does healthcare look like 10 years from now and 20 years from now? And often those of us who have been in it for the last couple of decades, it's hard for us to imagine, how that might look different. And there's certain things and certain modes of operating that have kind of been the same for the last 50, 100 years. So trying to imagine, a different future can be a little bit challenging sometime. And I think that, when these innovative technology companies come in, sometimes that can help just inject potentially a little bit different thinking into that process. But that's certainly, I think, something that even though you've been in the industry for some time, that you have the ability to sort of imagine, something that's maybe a different version of the future. And so one of the things that you and I talk about is peer review and what that looks like and sort of what that is today as an institutionalized, process within every hospital, but also, and what's great about it, and then, what sort of hasn't, or maybe isn't great about it. It's one of those sort of universal things where if I talk to, 100 doctors, they'll all complain about their peer review process. And it's odd to have this sort of function that's sort of universally sort of critiqued, and yet, I would say not enough solutions to sort of, maybe consider how it might be changed in the future. So anyway, so that's kind of our topic today. You want to chat with me about that?
Yeah, well, I mean, I think the first thing that you mentioned is this idea that healthcare is going to look totally different in 10 years than it looks right now. And I think if you ask most of us what the most important change that we're going to undergo, well, we're already undergoing it. It's really the transformation to value based care. And you hear that term thrown around a lot, but in the context of healthcare, value the value equation is some version of quality over cost. So value equals quality over cost. And so this idea that we're going to prioritize healthcare in a way that improves quality while lowering cost is it just permeating everything that we're doing in the way that we compensate physicians, the way that we grow our organization, on the insurance side. Um, Obviously, it informs a lot of the way we approach treatments. But what I'm seeing in the startup space and in the innovation space is that a lot of companies are figuring out how to get movement on that equation, right? And so when we talk about peer review, we are unquestionably talking about quality, and peer review is a huge component of the quality process at any healthcare institution, whether hospital, an office, a training program, whatever. There's almost always some version of peer review, and so the question of um, how do you make that better, and how do you adapt it to this new world we're going to be living in, I think is a great question.
Yeah, well, so let's explore that. One trend that we see is, and maybe I'll start with maybe more of the problem that I think we're all sort of aware of, is that peer review as it's done today, it's often involving, internal resources reviewing each other. And while that can be wonderful and a wonderful practice, and if it's the only way that peer review is happening, I think we're seeing the sort of, the chinks in the armor in some of that, right? We're seeing, I mean, and you've seen it too. You've got partners reviewing each other, you've got competitors reviewing each other, and the data that comes out of that process isn't necessarily data that's helping anybody.
Yeah, absolutely. I mean, I think it's the old the right to trial by a jury of your peers, but in the legal system, if you know those people, they are excused from the jury, right? Whereas often in our peer review process, we are reviewing people that not only do we know them, they're our partners, and as we discuss these things, they're in the room with us. And it would be, I think, in an ideal world, it wouldn't matter, and we would look at these cases absent who were the caregivers in that situation. But it's really hard to do, whether it's conscious or subconscious, when you know that that person you're reviewing is your partner, and you know everything about that person, and you also know um, what kind of stressors they're under, and the some of the mitigating factors, and frankly, you also know that they're going to be reviewing you. And
Right.
the old saying, "People in glass houses shouldn't throw stones," comes up a lot in peer review, right?
Yeah.
It's that you're going to have a complication, and you're going to be in that seat at some point. And so all of these things, um, color that process and make it um, so that it's not exactly what it's intended to be, which is this very unbiased review with the idea of getting to the truth.
Yeah.
And in getting to the truth, that you maybe find systematic um, or decision making elements that could have been done differently so that you can not have that happen again.
Yeah. And right. So, that's kind of like this one area of peer review that sort of gets, critiqued is the data itself good just because of what we're asking humans to do that know and like each other, right? And it's not to say that if they didn't know and like each other that, you know, bad things would happen. It just mean that you get to remove that element out of that interaction, and so that everyone can feel a little bit, less sort of biased and really just look at, the facts at hand, and hopefully that helps things get through. I think another thing that we see in peer review is we'll have this situation where, the specialist is being reviewed by someone who's not of the same specialty or of the same experience level, or not even by, if it's a doctor, by another physician, right? It might be a team of nurses that are reviewing physicians. So that you also have the problem of, when I'm trying to do these reviews internally and I don't have the equivalent resources, it's really hard for me to get those types of reviews done as well.
Absolutely, and I mean, and think about the smaller facilities, for instance, that might only have one of that specialist. Which I
Right.
dropped you. Sorry. Think about that. That particular smaller community hospital that might only just have one of somebody. Who reviews that person and gives them a fair shake if they're not in that same specialty. You could even think of a big practice, but a big orthopedic practice, but they only have one hand surgeon. So who reviews the hand surgeon, right? And so I think that's also problematic that you really, when you're in these situations and you're the person being reviewed, which I can just tell you from experience is pretty anxiety producing.
Mhm.
And one of the things that I think, um, really would hope for is that the person that's reviewing your case really understands um, the details of the clinical scenario that's involved, right? And that's hard to do unless you're in that specialty.
Yeah, that's right. And I just talked this week to a physician that actually wrote a big paper that on peer review itself, and it was the genesis of it was he was peer reviewed by a nurse, and uh, and it was an unfavorable review, and he will say, it was based on that she just didn't understand the medicine, as you know uh, another physician in his specialty would understand it. And so, it all ended up fine, but he had to go through this whole process, just because, the reviewer was not the right person to do it, right? Um, okay, so that's interesting, right? So we have this problem, these kind of two problems where, we have this sort of embedded bias with certain individuals that are reviewing each other. And then we have this disconnect between, what I'll just say is unqualified reviewers or reviewing an individual. And that is inherently the problem of, kind of only doing our reviews within this finite pool of, our employed physicians, our employed medical staff. So, when I think of what healthcare is going to be in 10 years and 20 years, I'm looking at other industries, what they're doing. I'm looking at industries that create, this, you gave me this term, but democratized access to to experience, right? To individuals with certain very specific backgrounds, that if you create an easy way to access them, then you sort of unfetter and you democratize, this ability to take really complicated, and really sort of experience driven areas of practice and be able to do just do more faster and get better quality of insights from the people that are involved. So, you look at other industries that are really good at this, and they've built marketplaces, and they've built platforms where you think of like the GLGs of the world, right? Where they go and they find the experts in all the different areas of life, and then they make those experts available to venture capital and private equity and hedge funds who, when it comes down to making a profit, they're very interested in talking to people with the right backgrounds. There is no interest in, I want biased results of any kind. It's, I need to get to the individuals with the deepest skill sets as soon as possible and really get to bedrock in terms of what truth is. So you have these industries like that do it really, really well. And it's that profit motive that sort of drives this, um, you know, uh, very like pragmatic, like, how do I get to truth? And I think that we can learn some things from that, and then we can start to apply it. And I think we can project ourselves forward in 20 years and imagine that medical specialty is a little bit more democratized.
Yeah, absolutely. So the fact of the matter is that um, medical expertise is really concentrated in certain geographies, and there's a huge opportunity to bring that expertise um, outside of the traditional brick and mortar um, confines that we've seen in healthcare. I think you're starting to see that a little bit with telehealth, right? I mean, you're seeing providers a little bit more able to see patients outside their geography. But in terms of expertise, um, I don't even think we've come close to scratching the surface of how do we give people that need access to experts, not necessarily for direct clinical care, but for everything else.
Yeah,
That absolutely has the power to improve healthcare quality.
yeah, yeah. I think that's right. And I mean, you look at, um, you know, there's a lot of money being spent by a lot of companies to find their way to medical specialists and get some sort of insight from them, right? Very inefficient sort of marketplaces out there, and I meet a lot of doctors who are, burned out right now, and they're trying to rebalance their lives, and they're trying to do other things, and they've accumulated a lot of experience that is really hard to duplicate, and it's hard to find anywhere else, and there's real value locked in that. And whether it's another hospital system that could benefit from that, or it's a company that needs that individual to look at a case. I think there's a ton of opportunity there. Just working with some hospitals that we work with, some of them are like small clinics, and you know you might be in the middle of nowhere, and you'll really need to access someone with some real experience, right? As another physician, and in figuring out how to do that, like and by the way, there's so many physicians out there that want to be reached. There's so many specialists that want to be able to provide that expertise. Uh, and so here you have like demand on both sides, but you don't have, and there's certain practical things standing in the way of that. Like, how do you find that person, and how do you create that interaction in a way that sort of mutually beneficial? And then there's other things that stand in the way of that, like you still have, in some systems you have like non-compete clauses, and you have things that are maybe even preventing doctors from doing certain types of work. So you've got some of those things in place. You've got also, how does the insurance of all of this stuff work, right? Do you need insurance to do these things? Where does liability come in with these different types of things? And you're seeing some innovative new things come out to enable that sort of thing. So I think as you see some of these little innovations occur, you're going to see a flattening of the world, and you're going to see more and more opportunity for specialists to really kind of be accessible to groups that could really use them. And I think you've told me this really is there's value in extending your influence beyond your geographical bounds, right?
Absolutely. Yeah. I mean, when you think about an expert, um, and when we say expert, I mean, I think obviously there's varying definitions of an expert, but when it comes to a particular clinical practice, um, for me, that's somebody that has been at it for a while and gained some real experience and deep subject matter knowledge as it relates to that clinical area of practice. They've probably been a busy practitioner in a busy place for a significant amount of years, 7 to 10 years at least, with good outcomes, right? Good track record from a malpractice standpoint, good standing in their community, high, level of referrals, right? It's hard to be busy and productive if you don't have a good referral base, which means that over time you build up the reputation to have good outcomes. So I think those are a few of the factors that go into being an expert. But my the point I was trying to get to is that if you have become that person, right, you have invested, first of all, a huge amount of money. The average physician's graduating, with a couple $100,000 in debt or more, and then you've had this huge opportunity cost while you were earning that knowledge. And so I think physicians are really excited to find ways to leverage and even monetize that knowledge beyond their traditional clinical roles.
Yeah. Yeah, it's funny in the tech world, you saw over the last couple of decades these marketplaces pop up where, it used to be, I need to find a full stack senior developer. And and to do that, I would start networking and I'd start asking around, and I would try to find someone out there that was available that I could hire as this full stack developer. And then over a couple of decades, you had these marketplaces pop up where I can go log in, I can punch in a search, and I can find some of the best full stack developers of specific technologies that I'm looking for, specific areas of the country or of the world, and it's delightful. And it fills this need on both sides. um, and you see these developers just able to create all kinds of income on top of like what they're doing, right? You see here a lot of moonlighting in the software development world. I know software developers that have made really, really great careers, just taking side work just because there are these more efficient marketplaces that have popped up that have enabled them to do that. And when you see that happening in the software world, it's not a hard leap, to imagine that happening in healthcare as well. And I think once you see that, you'll start to see a lot more efficiency. We talk about utilization, you talk about just efficiency and use of the talent that's out there. I think the industry 10, 20 years from now is going to be much more sort of fluid the way that other industries have been.
Yeah, I agree. I mean, I think there are those hurdles that you're talking about, but I don't think that they're insurmountable, right? I mean, and I think if that marketplace can be robust on both sides, um, and those transactions are easy, I think you're going to see that, to your point, really explode. I mean, the thing that I've been really surprised by in working with you and MedPlace is that the the physician demand side is incredible. I
Yeah.
mean, the number of physicians that want to do this type of work is it 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 really um, has been almost overwhelming to have to you know turn away physicians that want to do the work because typically if you're looking at trying to get physicians to do anything outside of their normal clinical role, we all get these emails about surveys or expert work, or like um, lots of different opportunities that sort of come your way. But usually you just you know delete them because it's either too onerous or too complicated, or it doesn't pay enough,
You
um,
don't even know if you'll get paid.
or you don't even know if you're going to get paid. And
Right.
so I think what you're saying about the efficiency of that marketplace being a real Kickstarter, I think that's true.
Yeah. I think something else that gets in the way in kind of coming back to peer reviews, and it gets in the way of doing, like when you talk about doing an independent peer review, doing it externally, right? Getting outside of your employed group to get peer reviews done. There's really philosophical differences out there, and it's a whole spectrum, right? There's hospitals that purposefully do more external peer reviews than they even need to, just because they're already aware of bias and they want to account for it, and they want to build a system that they feel really does inject real data back into their systems. And often you see that accompanied with a culture of not castigating, right? Mistakes are going to happen in the course of practicing medicine, and you see that come with the culture of you're not getting shamed, and I've seen really strong cultures where it's like, hey, our peer review process is robust and it's meant to be that way, and we all feel better about ourselves, as being part of it. And then you see, hospitals on the other end that, it's a punitive culture, and, so there's cultural things that get in the way. But there's also this like, I don't know that I want to like air my dirty laundry out there. I don't want to know. I'm not sure that we should let this outside of our four walls. And I think that when you look at modern technology and modern systems and other marketplaces out there, they've already accounted for those types of things, right? Uh, you can have things be completely anonymous, and it's kind of a different world. There's certain challenges or whatever with healthcare, but I think they're not insurmountable. But I tell you, we just had one of our clients was doing an independent peer review, and they were really the the risk team, who's actually led by a physician, right, which is sort of unusual, right? An actual MD leading the risk team, and looking at the history of reviews, and if they get them done externally, they get them done through like law firms, which sort of come with their own bias, and in really just wanting to talk to actual physicians, actually with clinical experience, that have done this, that are current in the medicine, that understand the realities of boots on the ground, and they just did their first review a couple of weeks ago, and it was great. There's no bias involved. It was very, this is what this is. This is the good, the bad, and the ugly. But this is what the medicine is, and here's the citations that we all want to look at, and the data to sort of back up this decision. And it was such a great conversation, between the risk department and this outside, uh, you know, clinician, that it was sort of exactly what everyone wanted. Even the provider that was being reviewed, right, being able to say, "Wow, this is somebody with the background that I actually feel um, proud to be reviewed by," and I would hope I would be able to do this for another colleague of mine. And I think that's where you land, is when I talk to doctors, they're really so interested. And you can tell me, from a physician's perspective, but helping another doctor in someone that you recognize as a peer, what is that like?
Yeah, I mean, for me, one of the things that I always talk about when I get an opportunity to talk to some of the other med place experts, or even when I'm talking to my own residents about this whole peer review process or the M&M, and I think that one of the things that you have to do always is approach any case you're reviewing with empathy, right? You got to approach the case with empathy for the patient who probably had something terrible happen, and then empathy for the provider, right? That was part of that care. And so, the first thing I do when I review a case is to like take a deep breath and think about, wow, like what was what must that have been like to realize that you cut a common bile duct, or that you didn't recognize that somebody was bleeding and they died. Um, and I always just take that second, and I think that what that does is it helps you to get to this place of like not finger pointing, not blaming, but just saying what really went wrong here and how could it have been prevented. And I think that's an approach that I think is really important, because what you would want, like you said, on the reverse, is that same level of empathy towards you and your care and towards your patient, and that somebody was really looking at what happened with an eye towards getting to the root of the problem and learning something rather than finger pointing. But you know, to go back to what you were saying about some of the barriers that these institutions have, and why they want to keep these things internal, right? And why they want to keep the system the way it is. I mean, I think the other thing that that um, you have to call out is cost, and the way a lot of these peer review systems work right now is that, like for me, if I get a peer review, then I just supposed to do it. It's part of my job.
Sure.
Um, um, but I think when you look at that globally, and if that's how all peer reviews are done, and if you pay nothing for something, then that you get what you pay for, and that's
Right.
why peer reviews take so long. Because if it's like if I have 8 million things to do, and if this is thing 8 million and one, and a lot of the other things I'm doing, I'm being compensated for, but I'm not being compensated for that thing. Human nature is that it will fall down the priority list, right? And if I'm not being compensated for it, um, you know, the amount of time and effort that I can put towards it, there's a calculus there. And
Yeah.
so I think, you know, there are not enough hours in the day for most physicians. And so if you just pile peer review on top of it, the quality of what you're going to get may not be what you want. Um, and, that's not to say that we don't do a good job on things because we're not paid for it, but it's just a question of how much time and energy can you devote to something.
Yeah.
And then the other thing, which is really key too, is that the manner in which that's conducted. If I only have an hour to devote to this, and 35 minutes of it is like, you know digging through charts and medical records and dealing with some peer review system, which some places have, which is archaic, and there's a lot of button clicking and whatever. Well, then, of the time that I could have spent, you know, providing better insights, I have now wasted on this terrible system of the way the case has been delivered to me and the way I'm supposed to deliver the information back.
So, well, so it sounds like we're all, especially you all that are out there practicing medicine, are asked to be doing more and more. Oftentimes that involves paperwork and administrative things that are hard. And then you have peer review that piles on top of that. And then you're asked to take that seriously. And you have to do that also with this like threat of politics behind it that you have to then navigate emotionally, right? And try to make decisions around. And here we are, humans inside of this system trying to do good by each other. And it just seems like the system is sort of set up, to not really. That's where the frustration is. I hear it a lot, and I don't know anybody in the system that's necessarily happy with it, but hopefully this gives people something to think about. And as they're looking out there, looking and sort of being self-introspective about their own, peer review program and other programs that they're running, to maybe try to think of different ways to do it. And imagine and start to build towards what is medicine going to look like in 20 years. Let's start building it now, and let's start experimenting now and seeing if we can not only get better data out, but also relieve the burden on our physicians in multiple tiers of burden there. and then, see if we can't, find our way through it with just a little bit to sort of a 2.0 kind of mentality on, how we're thinking about our quality and our delivery of care.
Well, it's ripe for innovation. I mean, I imagine in your work in this area, as you've talked to hospital administrators that might have a 500 case backlog of peer reviews, or as I talk to doctors that are both on the giving and receiving end of these reviews, I don't imagine you're running into a whole bunch of people that are like, no, it's working awesome. Like, I don't see any way that you could make this better. This is going great. It really does seem like an area that there could be a lot of um, um, technology and process applied that could make this better for everybody.
Yeah, I think that's right. Well, I hope that's right. That's certainly the mission that we're on, and I appreciate you for giving us guidance along the way. But yeah, Dr. Feinstein, Ara, thanks for joining me today. Appreciate the time as always.
Yeah, always great to, you and I are both always running. And so even just having a few minutes to just talk and think through some of these ideas, it's a lot of fun.
Great. Well, to all of you listening, thank you again for listening to the Reimagining Healthcare podcast. Appreciate you joining us, Dr. Feinstein. And again, if anyone has any interest in being a speaker, just email us at speakers@medplace.com. You can find Dr. Feinstein on LinkedIn. It's probably a good way to find you. Is there any other ways that people should try to connect with you?
That's probably the best one. That's where I try to connect with people the most. So yeah, I think that's probably your best bet.
I promise everyone you'll be entertained following Ara in his exploits from the clinic and onward. He really knows how to bring empathy and humanity to what can be a pretty difficult job sometimes. So I appreciate you doing that hard work, Ara. And other than that, thanks again for joining us, and we'll talk to you guys all soon.
All right. Thanks, Jared.